setting, right, sir?
Okay.
Anshu sir,
Yeah, thank you. Thank you very much. So good evening, everybody. I think today we are...
Sir, just a second.
Sir, I'll open the meeting and I will introduce everyone and then I'll hand it over to you.
Sir, we are live now.
Okay.
Yeah, okay. Sir. Right, so good evening, everyone. I'm Dr. Sanket Nivale, representing Medical Affairs at Emcure Pharmaceuticals. I welcome each and everyone for yet another episode of No Thrombosis Workshop series in acute ischemic stroke. With this, I would like to introduce our faculties tonight. We have our course director, Dr. Asokan sir. Sir is a senior consultant neurologist at Sri Ramakrishna Multi-Speciality Hospital, Coimbatore. President of Coimbatore Neurological Society, President Tamil Nadu and Pondicherry Association of Neurologists, presented papers in national and international conferences on stroke and epilepsy, conducted various international drug trial studies in the department, special interest in stroke therapy. Our moderator for tonight would be Dr. S. Meenakshi Sundaram, sir. Sir is a senior consultant neurologist, Apollo Hospitals, Madurai. Over 20 years of experience in neurology, presented papers at various prestigious national and international forums, recipient of Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology, Lucknow, 2002. Principal investigator for many international trials such as refractory partial epilepsy, stroke, acute stroke intervention trial, and PD trial. Editor of the South Asian edition of the book Practical Neurology by Jose Villa, Walter Kluwer, December 2020, and also contributed to many books on neurology. Our guest moderator for tonight would be Dr. Anshu Rohadge, sir. Sir is a senior consultant neurologist at Sir Gangaram Hospital, New Delhi, professor of neurology at SGRH, 50 publications in national and international journals, and actively involved in clinical trials in multiple sclerosis, stroke, Parkinson, and dementia, epilepsy, etc. We have our first speaker today, Dr. R. Ramya. Ma'am is a consultant neurologist, Tirupur Medical Foundation Hospital. She has presented paper and posters in multiple national and regional conferences. We have our second speaker for today, would be Dr. Lomesh Birud, sir. Sir is a consultant and interventional neurologist at Ruby Hall Clinic. Dr. Lomesh Birud has been trained to do cerebral angiography, mechanical thrombectomy for acute ischemic stroke patient, aneurysm coiling, carotid angioplasty and stenting, intracranial angioplasty, and stenting and various neurointerventional procedures. With this, I would like to hand over the meeting to our guest speaker today. We have Dr. Anshu Rohadge, sir. Over to you, sir, for context setting.
Thank you, Dr. Sanket. Thank you, Dr. Sanket. I think we can start the meeting and without wasting much time. And I think it's a good initiative by Emcure for having this workshop where we can discuss some interesting cases of stroke. So everybody becomes much wiser, and because stroke is I feel a very difficult area and a very tricky area sometimes. And all of us see a lot of difficult kind of problems. And I think sharing everybody's experience will go a long way in making life easier for everybody. So I think the two speakers that we have is Dr. R. Ramaya and Dr. Lomesh. I think they would show us some interesting cases and a wider horizon about stroke. So I would now request Dr. Ramaya to present the two cases of interesting stroke, and let's see what she has.
Ma'am, I'm sharing the deck on your behalf. Over to you, ma'am.
Respected seniors, very good evening, and to all the audience. Very good evening to one and all. Sir, I would like to give a background of where I work. I'm working at Tirupur, two centers at Tirupur Medical Foundation as well as Aadhar Medical Center, both of which are of secondary care hospital level only. So we have in-house CT and not MRI. So I started thrombolysis after joining here 2 years ago with the CT and CT angio alone. If necessary only, I can do MRI. And the people who come to our hospital are of low income group. So the cost is also a matter of concern here. With this background, I would like to enter into my case presentation. The first one I've given the name as the survivor. Mr. Muturaj, he was only 36 years. He was brought to us on 23rd October 2020 with a complaints of sudden onset of left-sided weakness for the past 1.5 to 2 hours at his workplace. He was doing his work. Then he suddenly fell down and noticed the weakness with slurring of speech and deviation of angle of mouth. He is a known hypertensive, but on irregular medication, he smokes and he takes alcohol. On examination, he was afebrile, hydrated well. He had right-sided upper limb and lower limb fixed flexion deformity after an RTA 8 years ago. And his sugar was 132 and BP was 240 by 140, both upper limbs. He had left hemiplegia. Right side was already fixed flexion deformity. And now he had left hemiplegia with severe dysarthria and facial palsy. His NIHSS at admission was 10. So we did CT brain, there was no bleed, and CT angio showed no major vessel occlusion. Next slide, please. So the BP was brought under control with the injection labetalol. Multiple drugs we gave, labetalol, clonidine, cilnidipine with the Ryle's tube, brazosine, and after attaining the BP of 150 by 100, and after obtaining the consent, patient was given injection tenactiplase 0.25 mg per kg at 2.5 hours window. He improved very rapidly. The score, NIHS score, improved to 2 from 10 by 2 hours. Both the patient and the attenders were shown the improvement, and he was planned for the follow-up CT the next day. Next slide, please. Patient was doing well for the next 10 hours, but then he became very drowsy, not obeying commands. So urgent CT brain was done, which showed a left parieto-occipital lobar bleed. The BP recorded at that time when the drowsiness was noticed was 130 by 90. He was started on mannitol and other anti-epileptic drugs. On day 2, he became conscious, alert, aphasic. He was restless but moving all 4 limbs. There was no worsening of the hemiplegia after the bleed. Next slide, please. So he had a sudden surge in BP noticed on day 2 again, 170, 110, with the worsening of restlessness again. Hence, planned for the repeat CT the very next day, which showed increase in the bleed in the same site with the mass effect and midline shift. So coagulation profile were looked into. There is no much increase. Next slide, please. So attenders were explained about the condition and need for referral to the higher center in case of deterioration. He may need a decompression like that, but they were not willing to go for the financial constraints. They also gave the consent, like even life-threatening events happen, they would like to manage here only, and they were not willing for surgery. So he was planned for secondary hypertension workup. Next slide, please. Continued on anti-epileptic medications, mannitol and other antihypertensives. On day 6, patient was improving clinically. He became more alert, obeying commands. He became ambulant with support, but the BP showed erratic fluctuations in between. It was maintaining, but then suddenly it shoots up. With 4 or 5 drugs, he was given cilnidipine, clonidine, isoleucine, and with these medications, his BP was telmisartans. With all these 4 medications, his BP was not under. It was under control, but again, it was showing erratic fluctuation. Why it goes up, we don't know. Then finally, we added labetalol on day 6. After that, the BP never raised above 160/100. On day 7 follow-up CT, the bleed was decreasing and he was shifted to ward. He gradually improved and a discharge on day 14. His cardiac evaluation and carotids were normal. They said they could do only 1 MRI. So we wanted the hypertension workup. We did MRI abdomen, that was normal. Renal artery Doppler was also normal. Next slide, please. So this was his discharge CT. Showing a huge bleed with multiple hyperintensities. Like he has not bled once. He has bled multiple times, but this was the discharge CT showing the resolving hematoma. Next slide, please. So this was, I'm sorry for this slide, it's not very clear, but this is the secondary hypertension workup. His aldosterons were normal, renin was normal, cortisol was normal. Only thing is the 24-hour urinary metanephrine excretion test was abnormal, with abnormal metanephrine and creatinine ratio. It was hugely abnormal. Up to 100 was normal, and he had 178 or so. So this was his discharge prescription with only cilnidipine, labetalol, aldactone, and antiplatelets and statins. Next slide, please. And this was his video. So that this video was taken when he came for the review last month. So that right-sided thing was a fixed flexion deformity of both hand and leg, but the left side weakness completely resolved. He was aphasic. He had also some visual disturbances because of the occipital lobar involvement, but everything recovered completely, managed only conservatively because they were not willing for any surgical intervention. He joined back his work, started earning again. That. Please. Same thing only. Next slide, please. So the lesson we learned here, very high BP, erratic fluctuations, though we didn't get anything specific for secondary hypertension, but it should be considered in young patients. And labetalol can be added earlier, even if we are not sure about the reason for the secondary hypertension. Huge or malignant bleed can also be manageable with adequate BP control and anti-edema measures, and the clinician to decide upon the intervention according to the clinical state of the patient. Next slide, please. So this patient, I've given him the name, the confuser. He was 56-year-old male. He is known case of bronchial asthma and hypothyroid, no habits. He was brought to...
Ramya, sorry to interfere.
Yes, sir.
I joined. Sorry, I joined a little late because I could not get the link. In due consideration with the other moderators also.
Yes, sir.
Can we take up the case this first and we'll go into the second case?
Yeah, I think that will be better, sir. I think that will
Yeah.
first let's discuss one case and then we move on to the second case.
Yeah, that's right. That's right.
Namaste, Ashokan sir.
Yeah, namaste. Sorry, I'm little late.
Sir, we are waiting for you, sir. It's a pleasure always.
Get the link on time. Meenakshi. So we'll go ahead with this first case discussion.
Yes, sir.
Yeah, Ella. No, the comments, Dr. Ansu, Dr. Meenakshi, who is going to take up?
Yeah, okay, I'll ask. So, you found that the urinary VMAs were high. So,
Yes.
So did you investigate further although the MR did not show any angio, the MR abdomen was normal. So did you investigate further for a pheochromocytoma?
No, sir. This much only I could convince them for the workup. They said they can do only one MRI. I preferred MRI abdomen. So I didn't do an MRI brain at all.
No, basically because you see,
MRI, that was also a contrast MRI, sir.
Yeah.
That didn't pick up any adrenal lesion or anything else. And there was no supine hypertension like that, sir. He had some erratic, that happens most of the time in around 2 to 3 in the morning. I checked the BP chart. 2 days, the BP chart will be fine. And the third day or fourth day, some huge rise in BP will happen around 3 to 4 a.m. That's all. So I thought something to do with the cortisol or so, but the levels were normal.
I think your cortisol levels were normal. So
Yes, sir.
I think because normally it's because we feel that the pheochromocytoma is in the adrenal only. So although the MR angio is the MRI and everything was normal, still I think we need to investigate and further to see if we're not missing a pheochromocytoma. Although I think he's done well with labetalol.
Yes, sir.
And the video you've shown was after how many months?
So this was just 2 months ago when he came for a review. This patient I lysed in 2020.
Okay.
He became all right within first review. He came with support. From the second review onwards, he walked independently, and all his symptoms disappeared in the second review itself. That is 2 months after thrombolysis, he became like this. I just took the video because I'm presenting this time.
Yeah. No, physically he looks fine. But what about the neurocognitive deficits? Because he had a lesion in the left parieto-occipital area, and he was initially aphasic. So
Yes,
did
he
you
was.
evaluate him? Did you
He had
evaluate him for
people-
the language disturbances, the neurocognitive, and the field disturbances?
So field disturbances, I made a chart with the ophthalmologist. Actually, there was no field disturbances, but he had some initial visual disturbances. He said so. At that time, I couldn't make a chart. After discharge, we sent him to the ophthalmologist. There was no visual disturbances. There's no field charting was okay. And the speech he was, his IQ was low from the beginning. They said like this only he speaks, but he is able to manage his work. He joined back his work and he was able to manage his work, and he was able to talk to his colleagues in a normal way, like as before.
Okay. And what was the level of work he was doing? Like it was a physical labor, because with such a bleed, we would expect that he would have a lot of cognitive deficits, reading and writing ability would be affected.
No, sir, he's doing a physical work only.
Physical work only.
Yeah, he just need to he just know to read and write, that much only.
Yeah.
He's well educated.
One more interesting issue. He was a left-hander or a right-hander? Because his right side was already deformed. So
Yes.
was he a left-hander or right-hander?
No, he was right-handed only. With that deformity, he manages. He works in a export company, doing that packing work and all. It's not even stitching. Stitching job he is not working. He's doing packing. Most of the time they have to stand. It seems they have to check whether the pieces are correct, and they have to pack. These two job only he does.
I think your message is very right. I think in young patients, we should always rule out for secondary hypertension, because I think the message sent across is he's very fortunate enough to recover.
Yes,
So
sir.
very well present and very well worked up in the kind of setup that you have. I think he has worked up very excellently worked up.
Thank you, sir.
Very nice case.
Thank you, sir.
Yeah, thank you, Ramya.
Thank you,
So
sir.
now the question is, I'd like to ask Dr. Vinakshi also. Thing is high BP, very high BP, of course, should put below the target level for power of thrombolysis. In spite of controlling this BP, after thrombolysis, he developed this bleed, massive bleed. Here, it seems BP again shot up, and maybe at the time of shooting up, he had another bleed, and subsequently would have had one more bleed also.
Yes, sir.
Because different ages of bleed seen.
Yes.
That's what in such of these cases, Enchanted study already told us two types of this thing. One is intensive therapy, another is recommended therapy. Intensive therapy, intensive control of the BP, that means you try to control the BP to as low as possible, and preferably below 80, and thrombolyze, and further try to control the BP in another 1 hour to the rates of 130 to 140 by labital infusion, sodium nitroprusside, or you don't use much of nicardipine. I don't use at least labital infusion or sodium nitroprusside. That is one aspect. Another aspect, again, the recommended try to reach the target BP, that is less than 180, thrombolyze, and try to maintain this under 180 for within 72 hours. But ultimately, in both cases, both the groups, they found out functional outcome is same. But only thing, the rates of bleed, IC bleed, intracerebral bleed, is slightly less with the intensive therapy. That's one point. Because your point, BP like this high, and otherwise fit for thrombolysis, but can we thrombolyze? Can you go ahead with this? And if you thrombolyze, what will happen? Isn't it?
Yes.
So this is the thing. You have to thrombolyze, but reach the target BP, either intensive therapy. But all Europeans, they would like to have intensive control of the BP. That is, try to bring it down to 140 water maybe within 1 hour and try to maintain it with some infusions.
Yes.
But the Dutch people, they still prefer in some centers that recommended target 180, reach within 7 hours and try to maintain it. Dr. Meenakshi?
Sir, agreed, sir. The same enchanted trial, it showed less than 140 to be equally beneficial. But as a routine, sir, we do not reduce the blood pressure, though there was one odd trial in my opinion. So I do not try to keep the blood pressure too low because my own fear of aggravating the deficits. Madam, one thing, fantastic, madam. As a very, very, very brave move, I should say, keeping the patient with such a large hemorrhage, most of the times we have had catastrophic results. That's a fantastic thing, madam. One contribution is that I didn't catch it. Was the renal artery Doppler normal, madam?
Yes, sir. Yes, sir. Renal artery Doppler was done. It was normal.
Normal. So
Normal.
that was really, and so we do not know the etiology behind this. Now, generally, when we tend to reduce the blood pressure, we have seen that the deficits go up. When you look at the guidelines says that you must get it below 180, 105.
Yes.
But how low you can get it, what is safe is not known. Ashokan sir called about the enchanted study, which was in a different perspective. How low you can move, we do not know because of the fear of enhancing the deficits. And I would like to know what was done to treat the hemorrhage there, madam, because that's the setting. Was it using, what did you use to treat them, madam?
Sir, I just control the, I started him on mannitol for as anti-edema and seizure medications only. The target BP, I told them it should be all the time less than 140/90. That was my target actually. And sir, before, at the time of receiving the patient, the BP was too high. But what I usually keep here is if I could bring down the BP easily, then I'll lyse. If it was very difficult for me to bring down the BP, then I will not lie, sir. I'll refer them only. Because the secondary setup, I have to face a lot of complications. So, but this man, he came around 2 hours window period. Within 30 minutes, I could control his BP. Because we give labetalol and clonidine parallelly. I gave first clonidine, and then it was not coming down. I gave labetalol. Immediately the BP came down. We have given through Riles tube cilnidipine and prazosin, thinking that will take care after 1 hour or so. After this IV labetalol goes away, that oral medications will take care of, I thought so. And so I was there for 2 hours. After lysis, I was there with the patient for 2 hours. He was doing well. The family witnessed that he started walking also. So they developed trust on me, so they don't want to go. And then at the time when he became drowsy, I rechecked the chart, sir. It was only 130/90 they have documented. I don't know how much to believe in the nurse's chart. And again, the second bleed happened after 1.5 days. That 1.5 days, the BP was okay. Then he had a surge in BP, he bled. Again, there was a control of BP, had a surge, and then bleed. Like that only. That was an erratic fluctuation. I don't know whom to blame. So after 2 bleed only, we added labetalol, thinking that it could be pheochromocytoma or some renovascular.
I was actually referring to the use of FFPs, madam. If we use FFPs, because we use cryoprecipitates, which is available with us, or FFPs. So you are really lucky that you got away without them, because our experience has been catastrophic. When we had a bleed, we know we are finished bleeding. Even young people, they come up with devastating deficits, and it's so wonderful to see your patient walking after such a huge hemorrhage, really. That's really, 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 I should say, God or goddess is with you. Otherwise, this could not have happened. Large hemorrhage, really. What is your experience, Anshu sir?
Yeah, that's what I was asking her. This patient is very lucky, and I think because he's not any neurocognitive deficits.
Huge hemorrhage is just.
Yeah. I think very, very, very.
Yeah.
Only thing I just want to add one thing is that when we're controlling the blood pressure, it's a double-edged sword, because it can go either way. You can have more worsening of deficits,
Yes.
Because a lot of
That's
time
why
we have
I
seen,
kept the target is 140/90, not
because
below
a lot of
that.
time when we admit this patient in the ICU people and they try to bring down the blood pressure too low. And then next day we found that the stroke has worsened. So it's a
Sir,
very, very double-edged sword.
90, sir. I think that is a safe thing to do. I
Yeah.
tell them 160/90, no more, less, no
Because
less than that.
even if you look the Enchanted trial, although they had less bleeds when they did control intensively, but it did not improve the neurological, there was not much change in that. The number of bleeds reduced, but the outcome didn't improve.
Yeah,
So I think
same here, sir.
you have to be very, very careful with the blood pressure. It's very difficult.
Yes.
And the previous trial showed worse deficits when you actually get down the BP.
BP
That's
down.
why they couldn't give any further conclusion beyond saying 185, 190. Sir, Ashokan sir, one doubt we want to ask, sir. We are not using sodium nitroprusside at all. So I'm surprised you are using it, sir. We are not using
we are using, and especially the patient happens to be in a coronary care unit with a stroke. They prefer still sodium nitroprusside. And of course, routinely we use IV labetalol.
We are using
The
IV
reason why,
labetalol.
because sodium nitroprusside also can increase the ICP. That's the reason why I asked, sir. Though nitroprusside has got the highest potential, sodium nitroprusside can also do that, and we do away with that. So what is your thinking, sir, in this?
Pardon?
It can also increase the ICP.
Yeah,
And
ICP. Yeah.
that's why we do not touch sodium nitroprusside. Nitroglycerin maximum potential, nitroglycerin nitroprusside also has a potential that we shy away from nitroglycerine. All our patients are only on labetalol. And I'm also told that enalaprilate is available. Cadila has brought enalaprilate now into the market. NVAS injection has come.
IV
Use that. Huh?
It's available. Now it's available. Yeah. Yeah, you can use that.
So I would like to ask something because the first blood I thought it was due to drug, maybe tinacti place. But the second blood, which happened after 1.5 days, I thought it is it's like a hemorrhagic stroke secondary to the rise in BP. So in that case also, should I use FFP? That's why I didn't use all those things actually.
Madam, the first FFP usage, basically when you have thrombolized. So this is a fibrinolytic therapy. The maximum chance of hemorrhage happens within the first 24 hours, with first 6 hours being the riskiest time. So our target is fibrinogen between 150 to 200. And in our hospital as a protocol, without questioning, we start them on 10 FFPs. FFPs are more freely available. For cryoprecipitates, we need to ask our blood bank and inform them and take and all those things. So straight away, our residents, they start. Straight away, FFPs, they start. I mean, it happens. One odd case, it happens. It's not a common occurrence, fortunately for us. And then up to 24 hours is when we monitor and do that. So beyond 24 hours happening is less likely because of thrombolysis, because the drug is cleared from the system.
Yes.
So what has happened, I do not know what was the reason. I need to understand why it has happened. But really, you are lucky that the hemorrhage did not expand, did not produce deficits further, and the patient came out clean after that. That's creditable, really. And it is a trust in you, madam. I should also say that.
And another thing, Dr. Meenakshi, like if, sorry, I was not the first 5 minutes. Dr. Ramya, known hypertensive or?
Yes, sir, known hypertensive, but he takes very irregular medication. He was given ARBs for his BP control.
One thing, so if hypertensive is causative for stroke, that is known hypertensive getting stroke. Long-standing hypertension not under good control, and such of these cases, and if you suspect and if you have the thing is facility for MR stroke protocol, this SWI, susceptibility weighted image, we can make out lots of microbleeds.
Yes, sir.
Microbleeds. No, what I'm telling you should do, not I'm telling you should do every case this is SWI. In such of this case, at least if you suspect anything, you can do and look for microbleeds, because the hypertension has occurred at the time of stroke. Not a known case of hypertension, but at the time of stroke, it's a different story. But known hypertensive getting stroke, that too on irregular treatment. Invariably, they present with lots of microbleeds. Such as this case, also you should be careful while thrombolizing.
Okay, sure.
Thank you. Thank you. Then no other questions. I think we'll go on with the second case.
Yes.
The second case.
Probably that's the reason she could do, correct, madam?
Yes.
She is in a setting where she has only CT scan, sir.
Yes. So this patient, he's a 56-year-old male. He's a known case of asthma and hypothyroid, no habits. He was brought to us on 25th March of 2022 at 8:30 for sudden unresponsiveness since 6 p.m. The time was so clean because he was having tea at that time. Then he suddenly fell down from his chair and became unresponsive. No seizure-like activity noted, no tongue bite, no incontinence. Next slide, please. So he was brought to our EMD in an altered mentation. He was flexing all 4 limbs to pain. His BP was 110/70. His sugar was 119. Pupils were equal and reacting to light, and occasional spontaneous limb movements on either side. He was actually clinically made a diagnosis of seizures, very patient in post-ictal state. So we generally, if I suspect a stroke, I'll ask for a CT, sir. Because MRI I have to send outside the hospital, little far away, 15-20 minutes travel from my hospital. So I thought it is a post-ictal state, so I referred him for MRI. New onset seizures, I should rule out some intracranial pathology also. But the MRI turned out to be bithalamic hyperacute infarct with no major vessel occlusion. Next slide, please. So this was his MRI. It was a hyperacute infarct and there was no major vessel occlusion. Next slide, please. Next slide, please. Next slide. So I explained to the attenders about the pros and cons of IV thrombolysis. They gave consent. So at the time of thrombolysis, I couldn't check his NIHs. GCS only I could check. E1, B1 and M4, he was flexing into the pain. No other clinical finding could be checked like gaze, speech or ataxia. He was given thrombolysis with the tenecteplase 0.25 mg per kg at 3 hours and 35 minutes of window. Though he came to me in 2 hours, because of this MRI, I had a little delay, but he improved and became conscious by midnight. He was given the drug at 9:35 in the night, and by midnight, I got a call like he became conscious. By next day, morning grounds, he recovered completely. Next slide, please. So the follow-up CT was done, no bleed. He was started on antiplatelets and statins. He was found to be diabetic during this admission, so started on medication for this diabetes also. He was discharged in stable state without any deficits. Next slide, please. So this was his video. Next slide, please. Actually, there's another video. I made him talk, actually. Sorry. So the lesson here I learned was, no, this is the same video. Stroke is not only a clinical diagnosis. At times I should do MRI also. Only thing is, it takes much of time in my setup. Since I have to send the patient outside the hospital, I have to go in ambulance, come back, and then we have to proceed. That's all, sir. Thank you.
Just one question. Can you go back to the CT slide? The MR, where what did it show in the artery of Percheron, the angio that you did?
No. So it was not showing artery of Percheron. There's no major vessel occlusion.
There was a report. The report, just go back to the
They
report.
have suggested it could be.
And then just go back to the next slide, which the report was written.
Next slide, please. Suggestive of artery of Percheron. So because of bithalamic, they have.
Bithalamic infarct. Okay.
Yeah.
So how much time did the patient improve?
So I gave the drug around 9:30 in the night, and from 12:30 onwards, he became conscious. By next day morning, 9 o'clock, he became very normal. He started walking, talking. and he started eating also.
Yeah, I think very good case, because most of the time we miss these patient comes in a comatose state, and by the
Yes.
time they reach us, the window is already gone. So and these
They
patients don't
came in
be,
2 hours. The drug was given in 3 hours 35 minutes, 1.5 hours late from our side.
so anyway, but it's a good case, good recovery.
And this is the first time I'm doing for a bilateral. I don't know whether this will get success or not. I told them everything openly, like there was a delay for 1.5 hours because we didn't suspect stroke. And this is the first case for bilateral stroke for me. And if they want to go also, better let them take the injection and go. They said, okay, we'll give the injection, wait, and then we'll decide. So because the patient improved, they stayed with us.
Anyway, very nice, very nice.
Okay, thank you, Dr. Mia. Dr. Meenakshi, your comments?
So it's a nice case. Thank you, madam.
Host, why you have disabled my video? Don't want to see my face?
No, sir, there is nothing like that we have initiated. Mayank, if you can help sir with this video, if you
Okay, it's all right. Go ahead.
right.
Any audio is there? Okay.
Madam, generally, posterior circulation, they have longer window. And that's one of the reasons why probably there was a gross discrepancy. I mean, the loss of consciousness does not correlate anyway with the images which you have shown. The complete loss of consciousness is not this one by that. Maybe in an image, if there have been some lesions which correlated with that, would have been very easy for us to know. In fact, if as a neurologist, if I had seen that, I'm not even sure that I would have picked up exactly those infarcts because they appear so symmetrical bilaterally that I know that I might have missed. I'm not saying that there's not that I'm saying I might have missed. So when there is a large, occlusion, it more often it strikes our eyes. These things really miss. But the loss of consciousness is really appealing there in that. So again, I feel that, and without a major vessel occlusive disease, there is no occlusion, the basilar, everything is perfectly okay. Still a patient is completely unconscious. It has taken me by surprise, madam. But as you have said,
It could be because of the ascending reticular activating system, because as per the report, there was a midbrain involvement also. I could not see. I could see only this bithalamic infarcts only. I could not see anything in the midbrain. If anything is involved in the ascending reticular activating system, they can have drowsy state also. I thought so.
The infarcts appear, what I'm saying, the infarcts appear too small in that it eludes my easy eyes. I mean, quick observation we tend to miss. So it should be there. And for the proof of pudding is that the patient has improved. And very importantly, one message which I have learned, Dr. Nasli Ichapuria sir, our senior, always used to say, there is no excuse not to thrombolyze. When in doubt, you thrombolyze, he teaches us. So I think that's a good message for all of us. When in doubt, let us thrombolyze and then think whatever is there later. So always never miss the bus for thrombolysis. It's a great case, really, madam. And again, the patient walking like that. You are really a lucky person, madam. Maybe I can think of referring my patients to you there. Even beyond the window, really.
Thank you, sir. By God's grace.
That's what another thing, as you said, that they can present with the total coma also, this artery of Percheron block, because bilateral thalamic infarcts and rostral midbrain, that's the area which is infarcted. So they can present with a short coma. And of course, if not the coma, altered mental status, gaze palsy, and memory impairment, etc., etc. But initially, when started with, when there was definite infarct shown and definite occlusion of the artery of Percheron shown in the angio, they were doing even intra-arterial thrombolysis. Probably now later proved IV thrombolysis as good as whatever it may be. Now you don't do intra-arterial thrombolysis, only IV thrombolysis, and they do get better. But only thing is differential diagnosis. Suppose we should not miss simple Wernicke's encephalopathy in such of these cases. There they can also present with bilateral thalamic infarcts, deep cerebral vein thrombosis, especially occlusion of the internal cerebral vein, where they can also present with bilateral thalamic infarcts, especially if you are very doubtful about the midbrain and only thalamic infarcts and the CVT and things like that, certain infections, all those things. Anyway, it's a very good case, and as Dr. Minash told, you are very lucky, and you got out of it. Yeah, that's what. We also had arterial percussion infarct some time back, but in that case, presented with the coma and a known hypertensive. Of course, we could treat hypertension and we thrombolized initially. But for her, it took nearly 1.5 months for the mental status to become normal. So she was totally rather, altered mental status, irritable, and whatnot. So even though she recovered from a coma, but higher functions did improve only after 1.5 months. Okay, thank you.
Thank you, sir. Shall I ask Dr. Birud to start his presentation, sir?
Yes, please.
Birud, sir, please, from your end.
Good evening, everyone. I'm Dr. Lomesh. I'm a stroke neurologist and a neurointerventional specialist at Pune. So without wasting time, I'll start my case. Is my slide visible to all?
Yes. Yes.
So we can see it in the sorter mode if you can just put it in the full mode.
Yeah, I'll just do that. Is it okay now?
Yes, sir.
So my talk is whether tenecteplase is a poor man's thrombectomy weapon or not. Whether this tenecteplase helps patients with opening the large vessel occlusion and which will avoid thrombectomy for these patients. Patients who has been LVO and not affordable for even IVT or definitely with MD. But
Sir, sorry to bother you, sir. Your audio is not clear. There is a lot of disturbance.
Audible now?
There is a lot of disturbance, sir, in the when you speak.
Is it okay now, sir?
Yeah, I think we can hear you now. Clear. Yes, go ahead.
Okay. So my talk is on tenecteplase whether it can be a poor man's thrombectomy weapon or not, because I have come across a case where the family was not even allowed us to give IVT. Somehow I convinced them to give at least tenecteplase.
Lomesh sir, just sorry for the interruption. Maybe you could do without the mic and just look at the computer and speak. The same thing is maybe that point where you have inserted the audio set into the computer is creating that noise. Sometimes it has happened to me. Yeah, now we can hear you clearly without the audio set, sir.
Am I audible?
Yes, sir. Clear.
Is it okay?
Better.
Okay, sir. Thank you so much.
Thank you, sir. Thank you, sir.
Yeah, we'll start with the case. This was an elderly female came to the emergency room on 1st of January 2022 when she woke up at 6 a.m. with complaints of right-sided upper limb and lower limb weakness, facial deviation, poor comprehension, and aphasic since she woke up. On medical history, she was a known case coronary artery disease, post-PTCA status, and hypertension. So on examination, her pulse was 93 per minute and it was irregular. BP was 160/80, CVS RH were normal, CNS conscious, poor comprehension, aphasic, left gaze preference, right human facial paresis, and right upper limb, lower limb power was 0/5. By clinical examination only, among all us neurologists will know that this is a major vessel occlusion and definitely left M1 occlusion. So NIHS was 18, MRS was 4, sugar was 124, and ECG was showing atrial fibrillation. There is loss of P waves. So this was in our center. We have a code stroke, and for code stroke, we do imaging as early as possible without wasting any time, and we don't ask the family to pay for MRI. So we did a MRI brain with Emcure, which was showing a developing left hemiatrial infarct in the basal ganglia, and there is a left M1 cutoff, and there was M1 thrombus. So after the scan, we have checked the list done for contraindication for IV thrombolysis. There was diffusion flare mismatch, so she was definitely a wake-up stroke IV candidate. Family were counseled for IV thrombolysis. Family member denied for IVT actually because the need for spending the money for tenecteplase. They are a CGHS beneficiary, so they went to take a memo for admission and treatment for acute ischemic stroke. Till 8:30 a.m. in the morning, I was there in emergency. Finally, family member came back saying office will open at 10:30. So by that time, we will not able to. Somehow, I decided to take a call, counsel the family member at least to allow us to give IVT. We will not charge for IVT, as IV thrombolysis is a life-saving drug. Then got convinced and patient issue injection connected plus 15 mg IV stat bolus. After IVT, we shifted the case to ICU and advised for mechanical thrombectomy. If time permits and patient does not improve because they are not able to give any kind of financial. So the video was pre-recorded before thrombolysis. You can easily see the case was on the left side. On the first one, he is not moving. On the left side, he is moving. In the evening, by evening only, slow stable, power was improved, speech was improved, and the comprehension was also improved. CT brain at 24 hours showed left ventricular infarction, and there was no evidence of the it was a large revision. Blood investigations were normal, as we know that there was a fibrillation. She was started on dabigatran and aspirin, and there was no carotid disease. So this was recorded in the follow-up. Is conscious, alert, comprehension is improved, speech is improved. Facial elevation improved. She is able to stand. Definitely, the connectiveness has helped this elderly lady. She is happy at the age. Question is, does connectiveness open up the large localism? So, what is the connectiveness? It is a third generation 3-point bioengineered artificial derived from marketplace. The advantage of marketplace is a higher specificity for filtering, longer half-life than altiplase, reduced binding to plasminogen activator inhibitors. A single bolus dose is available and has to be given, and fewer major bleeding complications when it was compared with the MI trials. Trials. Evidence of acquisition is true. So it is this was the meta-analysis of 5 major randomized controlled trials, and we showed it is non-inferior to altiplase, and the window was 3 hours, 6 hours, 4.5, and less than 4.5. So currently we are using as a not LPO less than 3 hours, and if it is LPO less than 4.5 hours. So Extend 1.8 PNK trial was published in 2018. So 22% of opening of the LPOs with the connectivities. Compared to altiplase, and modified Rankine scale also was improved with PNK.
So sorry to interrupt you, but we could barely hear you, sir.
Sir, maybe he can switch off his video so that this one will be better. If you just switch on the video, keep only audio on, maybe.
Yeah, I think that would be better because his bandwidth is not allowing him to speak. Of the video.
So just switch off your video, sir. Only keep your audio on till you complete the presentation, sir.
Okay.
Yeah. Yes, sir.
Is it good now?
It's better, but still we can't hear you.
I'll try this microphone again.
Am I audible right now?
Yeah, yes, much better, much better, much better.
Okay. So there are workflow advantage of altiplase over altiplase. First is shorter time to prepare, shorter time to administer, does not require dedicated second IV line, does not require IV infusion pump used to give for altiplase, shorter time to initiate inter-facility transfer when IV was lytic administration. And what are our advantage in our country are TNK can be administered more efficiently in LVO, permitting faster start of subsequent endovascular mechanical thrombectomy, cheaper cost as compared to altiplase, and thirdly, it does open LVO more than altiplase. So if you have an option of either tenecteplase or altiplase in LVO, we will definitely try to give tenecteplase than altiplase. So this was the last slide to comment on, because tenecteplase definitely works better in LVO. And is it possible that those are not affordable for the mechanical thrombectomy, straight away to push them for tenecteplase rather than giving them option of altiplase, which is much costlier and which require dedicated time to spend for giving the IV thrombolytic agent?
Yes, sir. Thank you, Dr. Lomesh. Thank you for your excellent presentation. And definitely, this in LBO's tenecteplase is useful.
Yes, sir.
As you have told, the extent IA trial also involved cases where it was definitely useful. But question is, sometimes, not every time, sometimes this, that only sometimes it helps, doesn't open the LBO totally. Altiplase, tenecteplase, I'm sorry, tenecteplase. In such a this case, that's why. That's why. One minute. That's why we plan for mechanical thrombectomy, especially M1 occlusion. So if the patient comes within the window period, definitely we can start with tenecteplase and meanwhile get the patient prepared for to go to the angio suite. If the patient is meanwhile improving, maybe we can wait and watch. And if the relatives are not willing for the mechanical thrombectomy, that time also we can give this IV tenecteplase and wait and watch. And if it is clearing, okay. Otherwise, I think you have to go for mechanical thrombectomy, especially if it is M1, because the results are very good. But some of the cases, as you have presented, they nicely open with tenecteplase, and there are studies supporting this, and you got away with that. Improvement was good at that age. It is really good. Yeah.
The advantage of using tenecteplase in this patient was, since it was a very small clot, but it was at the M1 segment. So the clot size was less than 8 mm. So we were very sure that it will lies with the thrombolytic agent. Which agent to choose? Generally, in wake-up stroke, the altiplase trials are there for diffusion flare mismatch. But for this case, we preferentially use tenecteplase because they are not willing for, even they have not brought this tenecteplase. It was the hospital fund allow us to give the tenecteplase. So the whole aim is to whether this tenecteplase opens up LVO so nicely, in especially in 20 to 23% of patients. Can we promote tenecteplase in LVO for each and every one? Because the advantage, you can easily transfer this patient for mechanical thrombectomy. Once the patient come to the major center where thrombectomy is done, if patient is improved, then well and good. If patient does not improve, we can shift to angio suite.
Yes, agreed. That is agreed. Very much agreed. So that's what. If the patient should have come within the window period, suppose the patient comes after 4.5 hours, then the question of only
Yes.
mechanical up to 24 hours.
Yes, sir. Yes.
And if it is within 4.5 hours, I think better start with tenecteplase and meanwhile plan for other things like angio, whatever it may be, etc., etc. And if the patient is lucky, and if we are lucky, maybe the clot will
get cleared by tenecteplase or altiplase.
Dr. Lamesh, two comments. Like how much time what time did you give the tenecteplase after how many hours?
She was a wake up stroke. She reported at 6 a.m. in the emergency.
Okay.
By 6:30, the scan was done. By 6:40, we counseled them. You have to give tenecteplase and you have to buy the drug for from the pharmacy. But they were not allowed. So by 7:40, 8:15, 8:20, we waited. By 8:30, my emergency team and I decided that let us push them for a thrombolytic agent and let the hospital pay for the whatever the amount for tenecteplase. Then they agreed to do that.
And, was the flare positive?
It was flare negative.
Flare negative. Okay.
Flare negative.
So okay. Okay. And you gave 0.25 mg per kg. No?
0.25 mg per kg. Yes.
Okay. In fact, actually, in this extend IATNK, they had done a subsection analysis, and even patients who were elderly more than 80, they found that even those patients, tenecteplase was better with the alteplase.
Yes.
So now, even now that the windows, even I think there are some trials which shown they're using tenecteplase up to even 24 hours. There is some
Yes.
Chinese trial. They use tenecteplase up to almost 24 hours.
Yes.
Just one, you have put the patient on dabigatran and aspirin. So
Yes,
what is
sir.
the logic? Like the patient is only has got AF, why not only on Dovax? Why did you add aspirin?
She is having a PTCA, post PTCA status. She is already known CAD. So she was already on aspirin. So we have not changed aspirin. We have changed only to 75 mg per day and dabigatran 110 milligram BD.
Okay.
Can I come in, sir?
Dr. Meenakshi.
Dr. Lomesh, sir, thank you very much. I
Thank you,
also
sir.
follow you on our stroke club, sir. Thank you very much for presenting.
Thank you.
Sir. I have something to ask you, sir. I have a real doubt to ask you here.
Yes, sir.
So we have faced this situation. We do an MRI. We see a major vessel occlusive disease.
Yes.
We give, IV thrombolysis.
Yes.
We take them up to the angio suite immediately after that, because as a policy, we do not wait for looking at any improvement.
Yes,
if the
sir.
patient is willing, we take them to the angio suite.
Yes, sir.
And when we open there is nothing there. It has opened up. So is there any way we can avoid this? Are you doing repeat imaging studies? Because even MRI, you could repeat it. If you have done a CT and CT angio, repeating it is not at all possible. So how do you come across this, sir? Because taking them to the angio suite is expensive by itself. So is there a recommendation to do a repeat angio before you take them for that? Because none of these studies have done that. I request you to guide me about this.
There is no recommendation that after IV thrombolysis, we should do immediately an angio to CT angio or MR angio to see whether the vessel is opened or not. In fact, it is sometimes it is not advisable also that once you do pre-thrombolysis and immediately you ask the family members to do another imaging study, you can see by clinical judgment if you want to avoid your patient is not willing for whatever the reason, you can clinically judge whether patient is improving the NIHSS scale or not. If the satisfactory NIHSS scale is improved, like more than 4 points, there is improvement, then you can say that there is a successful recanalization of the vessel is occurring. And if at all you want to prove the next scan, whichever you do, either a CT or MR, you just ask them to do an intracranial angio. That will solve your solve the purpose, though it is not recommended. But if you want to see that, or if you have some like thesis going on for any PG student, you can enroll that. But it is not any recommendation. IV thrombolysis, immediately shift to the angio suite. Just demonstrate if the LVO is clear, that's job is done.
Yeah, same things. The recommendations are there. But really what we are trying to do right away, sir, because of the fear that because angio, whatever said, and then it adds a lot of expense to the patient. The patient is already your patient. Fortunately, tenecteplase was given free by your hospital, but that will not be a privilege enjoyed in many hospitals, and you may not be able to enjoy the privilege every time.
Yes.
So we have tied up with the radiologists like this. In the stroke protocol, they do only MR, only the diffusion perfusion angio flap. In our hospital, we do only these 4 before we take them up for done as a diffusion, flare, and angio. Only these 3 are done. We don't do anything else. We come out of this suite. We do a thrombolysis, and we always say that something is pending there. So we show that into the account, and before the patient is wheeled into the cath lab, we try to look at that, as you have said, clinical improvement. And then there is also an improvement in the MR, again, when we repeat that, when you take that, after all, the technicians are your friends. So they do
Yes.
that, they are normal. And then we tell the family, maybe we can wait. Clinical improvement, angiographic improvement, nowadays we are waiting, sir, because at least 3 occasions I remember in the last about 3 or 4 years when we have gone into the suite room, tried to open and saw nothing is there. And then the family asked, why did you then come bring us here? I mean, you could have checked. So that really gave us that impetus. That is one comment there, sir. It is our own experience. I can't know what is right or wrong. I really do not know, because we are also in the learning curve regarding this. The second thing is that, sorry, sir. Yes, sorry.
Sir.
Yes.
The first question you can take in their words only. That's the benefit of giving IV thrombolysis. See, the thrombectomy cost has been saved by pushing the IV thrombolytic agent, and we are now very much sure that the large vessel is cleared by doing angiography. So you can tell in their language only that it was doubly benefit for us.
Yeah, same thing here, sir.
Yes.
And the second thing is about the utilization of connective place. If you look into our recommendations in our country, the DCGA recommendations, Dr. Sanket will tell us that it is for 3 hours. So as a policy in our hospital, in order to avoid litigations, what we are doing is that less than 3 hours, we use connective place and then go for a mechanical. If it is between 3 and 4.5 hours, it is always altiplace in order to avoid legal hazards. When it comes to this extended thrombolytic window, Dr. Anshu was talking about the Chablis trial from China, which showed up to 24 hours we could use tenecteplase. We had a small discussion before you joined in about the dosage requirements of being utilization of 0.32 milligrams per kg body weight. I thought maybe 0.4 was tested in NORT test and gave bad results, NORT test B, and then 0.25 we are using it very clearly. So they want to come in between the two. Probably it was halfway between 0.25 and the 0.4 is why they reached 0.2. That was my own guess in that, and it showed some benefits. Maybe when it gets established, maybe we can think of utilizing, this one. But DCGI, our recommendations stay with 3 hours. So what is your comment on that? Are you breaking the law there or anything? Have you faced any legal problems? One of our patients had a legal issue there. That's why I'm giving a caution here.
Yeah.
Being DCGI once.
Till date, we have not any legal litigation about using tenecteplase. We give both options, and we give the options about price also. When it comes to price, then they will immediately they will say that let us give this drug rather than giving altiplase. But definitely, if patient is affordable, or if your patient is willing to spend and they want level 1A evidence, definitely we should go for altiplase. No doubt in that. 4.5 hours, less than 4.5 hours, either LVO, non-LVO, you should give altiplase. By looking at the body language of the family and family members, we will able to understand what category they are. And the second category is tenecteplase. The approved dose is 0.2 mg per kg. Definitely in Indians, they have, I don't know why they have did like this. Either it should be 0.25 straightforward, LVO, non-LVO. In all cases, it will work. In paperwork, I don't write the weight of the patient on paper. I just give the amount of the drug, because at the same time you can judge. If patient is pelagic, you can't do the weight. It is always an approximate, so there will not be a difference of 0.05. So if it is with 0.2, if it is 14 mg, I'll just give 15 mg. If 0.2 it is 16, I'll just give 17.5 or 18. That is the way. You just don't put weight in the file. But I preferably give 0.25 mg, just to avoid my guilt of not giving 0.25 in LVO.
Sir, we are also using only 0.2 phase. Anshu was talking about
we are using 0.2. We are
0.25.
sticking to 3 hours. We are not what the DCGI has told. We are just sticking to that.
Yes.
Not to stick out our neck.
Yes. We should not also. But when there is a individual based question, like for my case, it was an individualized answer. So even they are not willing for but once they see the results, they are very happy that from their side, the doctor has taken right decision. So for them, it was beneficial because I studied the angiogram very clearly, and then only I took that much great step. Otherwise, I would have not also.
You gave a good, New Year gift to the family.
Yeah. It was
both in terms of the medication you gave free and spot-free individual really.
Disability free.
New Year gift.
Yeah, and it was on the 1st January. So I also wanted to do something good. So I was waited 2.5 hours in emergency just to convince them and let them accept that this drug will help them. And really it helped because of, I guess, positive vibes makes a major difference in this case.
Okay, thank you, Dr. Ramesh, for your excellent case. And I thank both the moderators, Dr. Meenakshi and Dr. Ansu, for their excellent discussion.
Sir, there is a question in the chat box, if you permit me, sir.
Please, go ahead.
Thank you, sir. There is Dr. Saurabh Jain from Bhilai, who wants to ask, TCD can help guiding whether vessel is opening up or not. Your comments, sir.
Yes, TCD will definitely help. We missed this non-invasive angiographic result. TCD definitely helps whether the vessel is open or not. You have to see the middle cerebral artery properly in the temporal bone split, and you can see that the vessel is open or not. You can see the very much good wavelength for TCD. The problem is it is not easily available. We need to get trained for doing TCDs, and sometimes if the bony window is thick, you will not able to see the MCA. So it is much more a operator dependent thing. So it is definitely help, but surely it helps.
Thank you, sir. Ashokan sir, that was the only comment there, sir.
I think in that case, I think yeah, anything? We had very good discussion and all very interesting cases.
One comment, sir.
Yes, please.
Yeah. Dr. Sanket, because brought up the question, Dr. Vijayan, who practices from Coimbatore, where Dr. Ashokan sir is also there. He is very fond of, he came from the Dr. Vijay Sharma's group. And in Madurai, he demonstrated to us as to how he does TCD to show the recanalization so that he can avoid a higher dosage of medications. Those days only altiplase was being used, and he used to run an infusion. He showed us that the moment the vessel opens up, he would stop the infusion further and let it go. So the dramatic decrease in the instance hemorrhage demonstrated to us. There were some interesting things which came with the TCD, and there was also a popular sonothrombolysis also. No more practice by us now. Thank you very much for being here.
Thank you, sir. Ashokan sir, your comments, sir.
Yeah, that's what we are winding up now. We had a very good session. I thank both the speakers, Dr. Ramya and Dr. Ramesh,
Thank
for
you, sir.
their excellent cases, and I both the moderators for their excellent discussion. We had rather very good learning curve. Thank you, all of you. Yes, hand over the mic to the host for winding.
Thank you, sir. Meenakshi sir, your comments.
No, sir. Sir, boss is finished. No words beyond boss. Thank you, sir. Thank you, Ashok. Thank you, Dr. Lo. Thank you.
Anshu sir, this was your first meeting as a guest moderator. Your comments, sir.
Yeah, I think I enjoyed it. I think it was good to listen from centers where MR is not available, to how difficult it is to do thrombolysis with CT, because I think most of us are using MR based protocols, and so I think it makes life much easier. So I think it was very good. We had Dr. Lomesh, who is a neurointerventionist, from a very different perspective to one where we use CT. So I think it was a good mixed bag. So I think it was a good experience. Thank you.
Thank you, sir. Thank you. Sir, officially now I would like to close by firstly apologizing for the technical glitch that happened in the starting of the meeting. Apologies to Ashokan sir for the video and the connecting problems that you had, sir. We will try and rectify the technical part on our end before we get into the meeting again. Again, and I really want to thank Ashokan sir for sparing his time as a course director for the meeting, sir, and participating and getting the interactions moving in the entire thing. I think we moved from 9 to 9:15 by just having this discussion, which happened today. I really want to thank Meenakshi sir and Anshu sir for their excellent deliberations and their sharing their experiences, clinical evidences, and making the case more profound for the listeners in terms of getting the exposure as to what and around the case that needs to be thought of. I really want to thank our case presenters, Dr. Ramya and Dr. Birut sir, for their excellent presentations in such a way that the listeners got an intro of exactly how the things move and what needs to be done, what were the steps taken, and what was the background around it as well. So a lot of learning curve which we got through the meeting. So I really want to thank all my delegates. We have approximately more than 200 logins and live audiences listening to us today. So thank you all the delegates also to spare their time for the meeting and having a take-home message from this meeting. Until next time, I request everyone to have a very good health and wish you a good evening ahead. Thank you all. Thank you.
Thank you. Good night. Bye bye.
Good night, everybody.
Thank you. Good night.
Ramya madam, thank you.
Thank you, sir. Thank you very much, sir.
Thank you, Dr. Lomesh. Anshu sir, thank you. And thank you, Dr. Ashokan sir. Bye.
Bye. Thank you very much.
Bye, sir.